Let's be real. There are few things in medicine more stressful than a pediatric emergency. I mean, the pressure is immense. Every single second feels like an hour, and having the right numbers ready to go can absolutely change the outcome. So that's what we're here to do. Get you those critical dosing numbers locked in for when you need them most.
So picture this. You're in the middle of it. A kid's heart rate is just screaming at 220. The monitor is going wild. What do? This isn't just some textbook question, right? It's a real-time call to action. The goal is to know the answer without even thinking, and that's exactly what we're going to nail down right now.
So here's how we're going to tackle this. We'll break it down into 4 simple parts. First, we'll talk about the SVT stopper, adenosine. Then we'll move on to the rhythm stabilizer, amiodarone. After that, we'll cover the electrical option, cardioversion. And finally, we'll wrap up with some absolutely essential pro tips. It's a clear roadmap. Let's get started. Okay, first up, adenosine. This is our #1 tool for supraventricular tachycardia, or SVT. You know, when a child's heart is just racing way too fast. This is the drug that can basically hit the reset button and bring that rhythm to a sudden and pretty dramatic stop. The protocol itself is actually pretty straightforward. It's a 2-step process. You're going to start with 0.1 milligrams per kilogram. And notice the keywords here, rapid IV push. We're going to come back to that because it's crucial. If that first dose doesn't do the trick, you simply double it for the second dose, 0.2 milligrams per kilogram. Nice and simple.
Now, here's a super important safety net. For that first dose, even if your weight-based calculation comes out higher, you stop at 6 milligrams. That is the absolute maximum for the first dose, no exceptions.
And you can probably guess what's next. Same idea for the second dose. If you have to give that higher dose, the maximum cap is doubled to 12 milligrams. These maximums are critical guardrails you have to remember.
Okay, this right here, this is the tip that makes the whole thing work. Adenosine has an unbelievably short half-life. We're talking just a few seconds. So if you don't push it in super fast and then immediately chase it with a saline flush, the drug will literally break down before it even gets to the heart. This technique isn't just a good idea, it's everything.
All right, let's switch gears to our next tool. So what happens when adenosine isn't the right drug or you're dealing with a really stubborn rhythm like VFib or VTAC? That's when we reach for amiodarone. Think of this as our heavy hitter, our rhythm stabilizer for those really complex, life-threatening scenarios. Now, the most important thing to know about amiodarone is that the context changes everything. Your entire dosing strategy hinges on one simple question. Does the child have a pulse? If the answer is no, you're in a code. You slam in 5 milligrams per kilogram as a rapid bolus. But if they do have a pulse, the situation is urgent, but you have a bit more time. You give that same dose, but as a slow infusion over 20 to 60 minutes. That one little detail, pulse or no pulse, is the whole ballgame.
And listen up because this is a big one. A huge, flashing red lights kind of warning. You never ever combine amiodarone with procainamide. Putting these two together can cause some really serious problems, including life-threatening arrhythmias. This is one of those non-negotiable rules you just have to burn into your brain.
Okay, we've covered our 2 big medications. So now, let's talk about electricity. What happens when a patient is unstable with a pulse because of a fast rhythm, and the drugs either aren't working or they're not the right choice? This is where we turn to synchronized cardioversion. It's basically a controlled electrical reset for the heart. And just like with our drugs, we follow an escalating protocol. You always start low, with about 0.5 to 1 joule per kilogram. If that doesn't fix the rhythm, you increase the energy. A good rule of thumb is to double it to 2 joules per kilogram. Now, if you're still not having success and you think you need to go higher, maybe up to 4 joules per kilogram, that is the moment where you absolutely need an expert, like a pediatric cardiologist, in the room or on the phone.
So we've gone through the numbers and the protocols, but now let's talk about the practical stuff, the wisdom that can shave off those precious seconds and really improve how things go. These are the kinds of tips you learn from being in the trenches. This is such a critical piece of advice. Look, in a perfect world, of course you'd want to sedate a child before cardioversion. But if that child is crashing, their blood pressure is tanking and they're about to code, you don't have time to wait for sedation. The #1 priority is fixing the rhythm. So you get the pads on, you make sure that sync button is on, and you deliver the shock. In that moment, saving their life comes before comfort.
Okay, let's do a quick lightning round just to lock this all in. Adenosine, remember it's 0.1, then 0.2, and you have to push it fast. Amiodarone, it all depends on the pulse. That's what decides between a fast bolus or a slow infusion. And cardioversion, you start low with the energy and you escalate methodically. 0.5, then 2, then up to 4 if you have to.
You know, at the end of the day, this isn't really about memorizing numbers on a slide. It's about building those mental pathways, that muscle memory, so that when the pressure is on and your heart is pounding, you don't even have to think. You can just act quickly and confidently. So the real question to ask yourself is, how can you take these tools and turn all that stress into focused, effective action in your next critical moment?